Hello, and welcome to the Chest Journal podcast, where each month we host a discussion with the authors of important articles from the current issue of the journal, adding context and commentary to the challenges facing clinicians in the fields of pulmonary, critical care, and sleep medicine. To introduce today's topic, here's your host, Dr. Alice Gallo de Moraes.
Hi, everyone, and welcome to the Chest Journal podcast. I'm Alice Gallo, an intensivist at Mayo Clinic, and today I have the honor and privilege to talk to Dr. Judith Brock about her paper on risk factors and clinical impact of severe pneumothorax after endoscopic lung volume reduction with endobronchial valves. Welcome, Dr. Brock.
Thank you very much for the invitation.
Thank you so much for joining us. So the first thing I would like you to share with our listeners is tell us a little bit about your work and what in your clinical work inspired you to do this research work.
Yeah, so I'm working at the Thorax Clinic in Heidelberg. This is a hospital for pulmonology, and we have a big endoscopy unit, for which it is also known. And I am working on a ward where I have patients with advanced COPD, many of them. And they come to us because they have tried everything, they have done medication and everything else, and they still suffer a lot. And so we offer them methods of lung volume reduction, and most of them get endobronchial valve implantation. So this is a whole ward only for these patients, so I see them a lot, and I see every complication that happens also a lot. And so these patients are really in an advanced disease stage. They really don't have many options, and they try out everything you can offer them. And if they get endobronchial valves and that works well, they have an increase of lung function, of exercise capacity and quality of life, and this is really nice. But there are some patients that develop pneumothorax, and some of them really suffer from pneumothorax, and I always find it hard to see these patients. And I wanted to better understand what are the differences of pneumothorax, when it is not so bad, when is it bad, what can I do to predict that and also to prevent that. And this is why I tried to get the data of all these patients and to summarize what happens to them.
That's amazing. I just want to make sure that I got that right. You have an entire ward just for patients with severe COPD?
Yes, they are there to be included in studies or to be offered different therapies of lung volume reduction. So this is the main and the major ward for that. Of course, sometimes there are also other patients on the ward, but mainly they are really advanced COPD patients.
That's fascinating. That's amazing. So share with our listeners, how did you design your study and what were some of the variables you wanted to look into, and what was your question?
Yeah, so first, from my impression, I saw some patients that had pneumothorax and everything went quite well. And also I saw some patients with pneumothorax and nothing went well. And so my first assumption was I will have to try to categorize these patients from a clinical point of view, not from a mechanistic point of view, but from a clinical point of view, and to make different categories like a mild pneumothorax, a moderate pneumothorax, and a severe pneumothorax. And I was mainly interested in the patients with severe pneumothorax. And so I have a really huge database on these patients because we see them every week and all over the years, and many of us have done valve implantation. So my first thing was to collect the data of these patients, of many of them. I wanted to have really many patients so that I also have many patients with complications, and to look retrospectively. What were the different features? What happened to them? How was the clinical course? And what can I learn from all these patients? Are there still things we don't know about pneumothorax? Can I in any way predict it, maybe?
I love that. And share with our listeners how you determine the severity of pneumothorax.
Yeah, so for me, the severe pneumothorax is a pneumothorax where the patient loses his valves again. So he got valve implantation, and then the pneumothorax is so severe that we have to explant part of the valves or all of the valves. And so the patient goes home at the end, and he has earned nothing. When he leaves the ward, he doesn't have atelectasis and he doesn't have benefit because he doesn't have valves anymore. Yeah. And also this brings with it that there are many complications because you don't lose the valves if you're doing fine. You only lose them if you have prolonged air leak or respiratory failure or you go to intensive care ward. So this was the severe pneumothorax, and then there were patients that don't even need anything. They don't need thoracic drainage. They don't need anything. They're just doing well. These are the best patients ever. So if you have a pneumothorax, but you don't need therapy for that, you are the winner of the valves. We already know that. And then there are some patients in between. They need, for example, thoracic drainage, but they keep their valves. So I put up these three categories.
That's awesome. And that's amazing. And for our listeners who have the paper in front of them, that should be figure 1, correct?
Yes, correct.
Awesome. Thank you. And so tell us what you found.
Yeah, so first of all, there are major or different categories. I had 530 patients, which is a lot. And first we had some data for all of these patients and just saw how huge is our pneumothorax rate. It's 19%. So if you look at the data in the literature, for some trials it's 7%, for some it's 10, others say 30. This depends on the patient selection. That doesn't tell you anything. It just tells you the higher the pneumothorax rate, the more patients with intact fissures you have selected. So this is nothing that tells you something, but it tells you how is this cohort. And I could already see in this cohort, and this was the first finding, that like everybody knows or thinks or assumes, that patients with valves put in the upper lobes have a higher risk of pneumothorax, and also patients that have complete fissures have a higher risk of pneumothorax. We already did know that, but I just wanted to be sure that this is still true. Mm-hmm. And then all the other findings are especially on the pneumothorax patients, which were 102 patients. And first of all, I saw that 1/3 was mild, 1/3 was moderate, and 1/3 was really severe pneumothorax. And firstly, we clinically categorized the course of severe pneumothorax, and we saw that really many of them develop respiratory failure, go to intensive care ward, they need more oxygen, they need maybe antibiotics, they need one drainage, they need a second drainage, and also some of them go to surgical closure of the fistula. So the clinical course of the severe pneumothorax patients really is worse, and it's not worth it. And it would be perfect if we would know which patients have such a course.
Yeah.
And the third thing was that the thing with these patients is they suffer a lot. Mm-hmm. And you won't believe me, but after such a stay at the hospital with one drainage, two drainage, surgery, the patients come back. And they ask you, please, doctor, I don't have options. Can you do that again? And we don't like to do that again. But sometimes we think, okay, it wasn't that worse. Maybe we could, because the patients are really begging. If you have them on the ward and you say we have to explant the valve, they're saying, oh, please, one more day, let's try one more day or 2 more days. And you see them and every day you decide can I wait another day or do I have to explant them because the risk is too high that something happens? So I wanted to know, if we reimplant the valves, if we decide for that, how often does pneumothorax occur again? And we found that the risk is really elevated. especially for the patients in which we had to explant all the valves. So for them, the risk is 75%. That is really high. And that changes completely our approach, because in the future, we will tell these patients, your risk is 75%. You really want to do that? Do we really want to do that? So this has a major impact on our clinical therapy and decisions that we do.
Yeah. And were any of your findings totally surprising to you? Any of them you're like, I thought it was going to be completely different than this?
Yeah, there were different things. So from my clinical experience, the curse of the severe pneumothorax patients is not surprising. This is what I saw. This is where I saw the need to put that down and write that in a publication. I wasn't sure how many of the pneumothorax patients have severe pneumothorax, and it's almost 40%, so it's a lot. I was surprised that it's really the left upper lobe that has this high rate. We knew that from former studies that there is an elevated risk from the upper lobes, but the explanation for that is not perfect. So we think that if you occlude the left upper lobe, the left lower lobe doesn't have as much space as the right side, and so the pneumothorax is worse. But to be honest, it's not a really, really good explanation. So I was surprised that this rate is so high for these patients. And also for the repeat pneumothorax, there were no data outside. So we didn't know what we would find. I also thought maybe the risk is higher, but I wasn't sure if it's really that high. And so this is also something that surprised me in some way.
Yeah, I was very surprised about the right upper lobe one too. I absolutely love your work and loved reading it. So what are the recommendations that you would give to our listeners moving forward based on your findings?
Yeah, so there are several things that I changed in my daily practice immediately after that.
Love it.
So yeah, if I have a patient right now and I tell him where he will get valves, I tell him the risk. And if he gets valves in the left upper lobe, I don't tell him you may have a risk of 20%. I say you have a very elevated risk for pneumothorax. You have to know that before. I can tell you if you have it or not, but the chance is much higher than if you implant valves in the left upper lobe, lower lobes. And if I have a patient where I want to implant valves in the lower lobes, I'm quite chilled, and I think, okay, if I need charges measurement and it's the lower lobe, nothing will happen. So if it's a patient that is not in that good general condition, I try to risk that if it's the lower lobe, but not if it's the upper lobe. So this changes the approach and also what I tell the patient. And also if the patient wants reimplantation of valves, I can now tell numbers. I can say your chance of repeat pneumothorax is 75%. That's really high. It's quite guaranteed that you will have it again. And there's also a chance that you will again lose the valves. Are you sure? So of course I cannot tell them 100%, but I can give them a better estimation of how high the risk is. The only thing that is still not answered, and I'm really trying to work on this, is how can I in future know that this patient is the severe pneumothorax patient? We need kind of a prediction score for that we didn't find in that publication right now.
Yeah. So you're working on a prediction score?
Yes, we will try to complete the data set because we didn't have all data of all 530 patients. We didn't, for example, not have all exact CT data on bulle or everything, and we didn't have the data for the QCT, so for the emphysema index, but we will complete the data set and then try to develop with statisticians some kind of score that will help us really to predict who is the severe pneumothorax patient.
I love that. And any take-home points, like main points that you would like our listeners to take away from our conversation, from the work that you have done with your team so far?
Yeah, so first message, this is not a publication that tells you don't do valves. This would be the wrong message. You do valves. This is a very nice thing for the patients. Yeah. But now you have some better ideas when a severe pneumothorax will happen. And if you are a center that is not very experienced with valves, maybe you don't choose for a patient with left upper lobe and a worse general condition. Be aware that then the risk is high and you really need a good setup in your clinic. You need a thoracic surgeon who can be there. You need an intensive care ward. So just be aware there is a risk that something really bad happens, and it can be handled quite good if you're experienced with that. But if you haven't seen that before, maybe just change and only take the patients that are in better condition. And this is something I would advise all clinics to do. And I can also say that most of our patients, despite all these data, they are doing quite well. They recover after all of that. And many of them, as I said, come back and say, could you try that again? So this is the only thing why we could justify all of that. Yeah. And we need to get better in predicting that so that we really know who is this way and who is that way. And talk to your patient. Tell him the risk. I always feel like if the patient knows and if he says yes to the procedure, despite he knows, I personally feel much better with the decision.
Yeah, I love that. I love that. Dr. Brock, thank you so much for joining me and the Chest Journal podcast listeners. I truly appreciate you spending this minutes with me today. And to our listeners, I just spoke to Dr. Judith Brock. We talked about her paper in our most recent volume of the journal, Risk Factors and Clinical Impact of Severe Pneumothorax After Endoscopic Lung Volume Reduction with Endobronchial Valves. Dr. Brock does advocate for us to keep placing valves, but to have a very good conversation with our patients and a good plan for those who are at the higher risk of having a pneumothorax as a complication. Thank you again so much, Dr. Brock.
You're welcome. Thanks a lot.